Wisdom, TIRO's podcast designed to share thyroid cancer pearls of wisdom from clinicians for clinicians. Think of it as a fireside chat where we talk to international experts who share their wisdom, offering practical advice to clinicians in a variety of common and sometimes complex clinical situations. I'm your host, Dr. Dana Hartle. I'm an otolaryngologist and head and neck surgeon at the Gustave Roussy Cancer Center in France, and it is a pleasure for me to welcome you to TIRO's Voices of Wisdom podcast. I will be hosting the second season of Voices of Wisdom, stepping into the shoes of Dr. Janice Pasieka, who pioneered these podcasts. I want to take this opportunity to thank Janice for all her hard work on making these podcasts a reality, and congratulate Janice and all of those who've contributed to the success that these podcasts have become. We created this podcast to provide clinicians with short, easy-to-digest highlights of clinical issues that we all face while treating cancer patients. Our aim is to share evidence-based information as well as practice-based experience and tips from world-renowned experts. In each episode, I am joined by distinguished international guests who bring their unique perspective and expertise to the discussion. So whether you're a surgeon, an endocrinologist, pathologist, medical oncologist, or a nuclear medicine specialist, this podcast promises to be a pivotal resource in your quest for knowledge in the care of thyroid cancer patients. In today's episode, we're joined by Dr. Catherine Sinclair from Australia for a practical conversation about intraoperative neuromonitoring in thyroid surgery. From the different types of neuromonitoring and when to use them, to global access challenges and what non-surgeons need to know, Dr. Sinclair offers real-world guidance and reflections that every thyroid clinician should hear. Dr. Sinclair is board certified in otolaryngology and head and neck surgery in both Australia and the United States, with advanced fellowship training in head and neck surgery and laryngology. She is editor-in-chief of Video Endocrinology, a leading voice in thyroid surgery. Dr. Sinclair has published extensively on operative techniques and is pioneering innovations such as continuous vagus nerve reflex monitoring and radiofrequency ablation for thyroid nodules. So let's get started. Catherine, thank you so much for being on the show. So I'm going to start right off with the first question. How would you define neuromonitoring in thyroid surgery? People say, oh, it's got something to do with electrodes, but is there a working definition for that?
So firstly, thank you so much for having me speak in this podcast. It's a real honor to be here. So when we talk about neuromonitoring in thyroid surgery, we're really talking about techniques used to assess the functional integrity of laryngeal nerves. And so in more layman's terms, we're really trying to work out, is a nerve working or not? And the nerves that we're particularly interested in are the nerves to the voice box, because they are the ones, just by virtue of anatomy, that lie directly on the thyroid, be it the external branch of the superior laryngeal nerve, which comes in from the top, or the recurrent laryngeal nerve, which runs up behind the thyroid lobes. And so these neuromonitoring techniques are ways of assessing what's happening inside those nerves whilst we're operating. And obviously what's happening inside the nerves may be very different from what we see when we just look at a nerve, which of course doesn't tell us anything about the internal function of that nerve.
And so you're saying techniques, plural, that means that there are different ways of assessing nerve function. Can you go into kind of the details of what different techniques there are? What technique you can use?
Absolutely. So when we think about techniques of nerve monitoring, there's a technique called intermittent nerve monitoring, and there's a technique called continuous nerve monitoring. And similar to what the name suggests, the intermittent monitoring is basically where we stimulate a nerve, in the case of thyroid surgery, the laryngeal nerves, at various times during a surgery. Now, there are no specified times per se, except that at the beginning of the surgery, we should stimulate the vagus nerve and the recurrent laryngeal nerve to get opening potentials. And at the end of a surgery, we should stimulate them to get closing potentials. But during the case, there's really no set interval at which point those nerves should be stimulated. So it's really surgeon driven. That means that whoever's operating decides, oh, I've been operating on the nerve, I better check that it's functional, and will stimulate the nerve, usually with a handheld nerve probe, although are a few other ways that can be done. But generally, some form of probe is used to touch the nerve and see what its function is at that moment in time. And so that's the intermittent form of monitoring. And obviously, that has pros and cons, and I'll speak about those maybe in a moment. So, the continuous form of monitoring is where the nerve is stimulated continuously during the surgery at very discrete time points. So, usually, it's stimulated every couple of seconds. And what that does is it allows the nerve's function to be tracked at every time point during the surgery. So it's a continuous sort of trace that you get of what that nerve is doing at any given moment, as opposed to intermittent, where it's really the surgeon that determines when they want to know what the nerve is doing. And so, in line with that, there are obviously pros and cons of both. And intermittent is very easy to do because you just need a handheld probe and then you need a nerve and you can stimulate it and you can get potentials. Now, that can be useful at the beginning of a surgery, or if you're operating in someone who's had surgery before where there's a lot of scar tissue and you want to find where the nerve is. And that's what we call mapping. So we use the probe to sort of scan over the tissue to get an idea of the location of the nerve. And then we're better able to dissect that nerve out with more knowledge about exactly where it is to be found. And so that mapping function is a very useful tool that can be done with intermittent monitoring. And similarly, intermittent monitoring can give us, as I mentioned, opening and closing potentials, so we can see at the end of a surgery, is the nerve working or not? And if the nerve is not working, in which case you would not see a potential when you stimulated the nerve, and you wouldn't be able to feel any twitch of the laryngeal muscles when you stimulated the nerve. That may then be an indication, if you had planned to go over to the other side and do a second, if you were doing a total thyroidectomy, maybe an indication that that's not a good idea and that maybe you should stage the surgery. And so that opening and closing potentials and the ability to stage surgery is, again, another real benefit of intraoperative intermittent nerve monitoring. The problem with intermittent monitoring, of course, are those time periods between the surgeon-driven stimulations. So you may stimulate it and then maybe you start dissecting around the thyroid. Maybe your assistant is retracting on the thyroid and you don't really know what's happening to that nerve functionally. And so the advantage of continuous monitoring is that even when you're doing those maneuvers where you don't have the probe in your hand and you're not touching the nerve directly, you're still going to see what's happening with that nerve function. And of course, if you kind of extrapolate that, in theory, it suggests that if the nerve function is declining, it may give you early warning of that and allow you to do something potentially to bring that function back or stop it declining further, i.e. maybe changing what you're doing, changing the position that your assistant is pulling the thyroid in, stopping the surgery for a while and letting those potentials recover. So continuous monitoring gives you that continuous functional assessment that, in theory, and we'll talk more about this probably a bit later, potentially could prevent nerve injury, whereas intermittent less so, has probably less of an ability to prevent nerve injury, but intermittent has an ability to identify a nerve that might be hidden. But the continuous monitoring will not allow you to identify the nerve, but will give you that continuous feedback. And so the two techniques are very complementary, and you can use intermittent nerve monitoring for mapping and for finding a nerve and for checking opening and closing values, and then continuous monitoring you can use for the in-between times when you really just want to see what the nerve is doing when you are doing various things during the operation.
That's really cool. It's kind of all or nothing with the intermittent nerve monitoring, and then more of a gradual warning sort of a signal that you can get with the continuous. You can still, though, do mapping with the continuous. You still have a probe that you can use.
Well, then that would sort of come in under the intermittent form. But yes, absolutely. You wouldn't really want to just use continuous and not have the probe for identification purposes and, checking whatever the continuous monitoring is telling you. If it tells you you've lost signal, you probably want to check that with the probe as well to check that isn't just that an electrode's come loose or something. So they work really, really well together. That's exactly right.
Colleagues say, well, I'm just doing a lobectomy, do I really need neuromonitoring, for example?
I think when we start trying to weigh up whether nerve monitoring is useful, it does become quite a controversial area. And I think perhaps it's become less controversial over the past 5 or 6 years. There's been a number of studies and big systematic reviews, meta-analyses, fairly large trials that have shown clear benefits. And definitely in my mind, there is a clear benefit. And that benefit is really whether you're doing a lobectomy or a total thyroidectomy, because we want to obviously give our patients the best outcomes we can. And if there's a methodology like neuromonitoring that can optimize outcomes, it seems silly not to use it, provided it's able to be used safely and fairly easily. And so, in my mind, it's not so much the type of thyroid surgery that dictates whether or not monitoring is useful. I think it really is useful in all types of thyroid surgery. I think choosing between the different types of techniques is more nuanced, and I think that, as we just mentioned previously, there are pros and cons to both. But in my mind, continuous does give superior ability. Well, really, it's the only form of monitoring that gives an ability to potentially prevent injury. I think intermittent, if you stimulate that nerve enough, you probably can get a time course, and maybe you'll see the potentials are gradually going down and you can get a warning and do something, but it's still not as good as having continuous, almost second by second or every 4 seconds, impulses that tell you what that nerve is doing, even when you may not be thinking much about the nerve. You might be on a different part of the surgery. So it is a gray zone. And, when people ask, but does it make a difference? I've read studies where it doesn't make a difference. They're absolutely right. If you, do a Medline search and look up neuromonitoring and thyroid surgery, you'll find thousands and thousands of articles, numerous case studies, a number of randomized studies, and some of them are looking at intermittent monitoring versus visual identification of the nerve alone. Some of them, particularly the more recent ones, are comparing intermittent to continuous nerve monitoring, and kind of trying to sort of read between the lines and work out, was the study well done? Why is that study giving this outcome that says there's no difference, whereas this study is giving a difference, can be really quite difficult. There are a number of reasons for that. One of three probably main reasons is that until recently, there wasn't really good standardization as to how to do nerve monitoring. It was, well, neuromonitoring, you probe the nerve and then you check and see if it's got function, and that's good, and if it doesn't, that's bad. But there wasn't really a set methodology as to, well, how do you go about it in intermittent monitoring, for example? What should be your sequence of stimulations that you should always do at the beginning of a case and the end of a case? And I think a group called the International Neural Monitoring Study Group, that was formed originally by a group of, physicians and surgeons who have a real interest in nerve protection and nerve monitoring, and they've really put out some amazing publications in the past decade, and the ones that probably really defined a paradigm for how to do nerve monitoring well, or at least kind of standardized. There were some publications in, I think it was 2018, which looked at the use of nerve monitoring in staging surgery in the case of a loss of signal, when the plan was for a total thyroidectomy, and the use of nerve monitoring in cancer surgery. And those two papers really, if you're not familiar with them, I'd really encourage you to have a look at them, because they very nicely set out algorithms and ways of doing nerve monitoring that has helped really standardize reporting and studies since that time. And so that's one issue with the earlier studies, this lack of standardization of actually how to do nerve monitoring. And then following on from that, of course, is what I see as another real deficit, particularly with the earlier studies, is what outcomes should we actually be measuring with nerve monitoring? And so when we're trying to write papers on, is one technique better than another, you really have to have outcomes that are feasible and that are able to be measured. And so most papers are focused on the prevention of vocal fold paralysis or, nerve injury causing vocal fold paralysis as the main outcome. But as we, just discussed earlier, intermittent nerve monitoring, although if you do it enough, perhaps it can help prevent paralysis just by virtue of you being able to see a bit of a trend in your intermittent stimulations or by virtue of helping you find a nerve that otherwise would have been hard to find in a scarred field. But apart from sort of those indications, intermittent monitoring, because it's intermittently done, isn't really going to prevent an injury from happening because you're not going to know what is happening to that nerve every second of the time. And so when I look at papers, and that's the main outcome, and they're comparing intermittent monitoring to, say, visual identification and not finding a difference, I'm not surprised they haven't necessarily found a difference because perhaps that's the wrong outcome to be measuring. And we did a consensus statement on this, looking at what outcomes should we be measuring. And I think that was in Head and Neck in about, I think 2022 that was published. And it kind of, we tried to define a little bit more, if you're using intermittent monitoring, maybe looking at how many times, did you have to stage surgery, how many bilateral vocal fold paralyses were prevented, might be better outcomes to measure. And similarly, I think a recent study from a couple of years ago out of Korea looked at the diagnostic accuracy of nerve monitoring using intermittent monitoring, but basically looking at what the nerve potential was at the end of a case and whether that predicted post-operative vocal fold motion. All patients were examined by, with laryngoscopy. That was actually a systematic review, but they looked at numerous patients. I want to say there was, maybe over 19,000 patients in a number of studies, and really showed that the diagnostic accuracy is excellent. When you're looking at that as your outcome, does it predict vocal fold paralysis or not? Not does it prevent vocal fold paralysis? So I think when we're talking about, the heterogeneity in the studies to date, part of it is that the outcomes that have been measured are not always appropriate for the type of monitoring. And similarly, when we look at continuous monitoring, there are lots of ways a nerve can be injured. So a nerve can be stretched, and traction injuries are definitely the most common. And, it's with an estimated probably 80 to 90% of injuries are thought to be traction-related injuries, where it's stretch over time that causes the nerve to stop functioning. But there's also other injuries like transection, where the nerve is cut, or, where the nerve is burnt, heat-related injuries. And these injuries, when they occur, unlike traction, they can happen in the blink of an eye. They can happen like that. And yet studies never report on what mechanism of nerve injury occurred in that series, because no form of nerve injury can stop a surgeon accidentally cutting a nerve. No form of nerve injury can stop a surgeon accidentally bipolaring right on a nerve and causing it to, its potentials decline. Perhaps continuous monitoring can prevent traction-related injuries that are slowly evolving over time, because it can allow you to rest the nerve if you obey the information that you're receiving. But again, we don't ever get any information really about the type of nerve injury in these papers. So it's very hard to, in the ones that say there's no difference between, even say between continuous and intermittent, well, were the nerve injuries a sort that actually could have been prevented by nerve monitoring to begin with, or were they not? And so that's another kind of issue when I look at these papers. And I guess the final thing is, which sort of goes hand in hand with that, is nerve monitoring data that we get during surgery is only as good as the technician who's doing the surgery. So, we're getting this data either intermittently or continuously. If we're not paying attention to it and if we're not acting on what it's telling us, it's definitely not going to be able to do what it should be able to do. So if I see a nerve potential going down and I don't rest the tissue or give the nerve a bit of a break and I just keep on going, the nerve's probably going to go out. And that really is my fault for not listening to the information provided. And I guess that brings up the question of passive monitoring, which we see with junior doctors and residents, where the machine is switched on And then that's good. The machine's on, it's going to kind of protect the nerve. That's great. And funnily enough, sometimes when you stimulate tissue with the neuroprobe, you will get a sound from the machine that sounds like a nerve potential. You'll get a very bip, it sounds like it's a nerve potential. Now, if you don't look at the screen, you will think that that is the nerve and you will kind of go on with your dissection, assuming that's a nerve. But if you look at the screen, oftentimes what you'll see is just a flat line. You will not see a nice CMAP potential, compound muscle action potential. You'll literally see a flat line, and that is not a true potential. And it happens to me numerous times during a case, and my assistant's very used to looking for it now. I'll be like, is it true? And she's like, no, not true. Because there'll be a flat line, yet it will sound a little bit like it's a nerve potential. And so, again, you have to act on the information you're provided with, and you have to have an awareness of how that information looks and what to do with it when you see it. And so I think, for all of those reasons, outcomes reporting, standardization, and, variability in how nerve monitoring is done and how responsive individuals are to nerve monitoring, the data is very muddy. And I would say that out of centers where I know that, the people, they do a lot of thyroid surgery, they're very good at nerve monitoring, very attentive to what the data is telling them. There is no doubt in those publications that nerve monitoring makes a difference, and that nerve monitoring can help, if it's continuous, prevent nerve injury, but definitely can provide valuable information during a case, be that a lobectomy or a total thyroidectomy or a cancer surgery or a benign nodule surgery. And so, so long answer to the question, but it's, it opened a bag of worms, and I think it's important to kind of discuss all of these things, because this is the reason there's been controversy. These are the reasons behind that controversy, and it's just sort of important to go into them a little bit.
It was a great answer. I think I remember an old study kind of at the beginning of neuromonitoring. Surgeons who were used to doing neuromonitoring actually even had better outcomes than without the neuromonitoring. It's that the neuromonitoring makes us more aware, makes us more careful. So I think, as you said, it just, we are, when we're aware of what's going on, when the signals are telling us, even without the signals, we're more careful around the nerve.
We developed a method of continuous monitoring using the laryngeal adductor reflex at Mount Sinai a while ago now, and that's currently in development for more sort of widespread use. But using that continuous monitoring, and it doesn't matter what type of continuous monitoring, but that actually changed the way I do thyroid surgery. So I used to do superior pole dissection first. We found that there were a lot of transient declines in recurrent laryngeal nerve potential when I was doing that, and I flipped and did inferior pole dissection first, which I still do, and we found that there were a lot less declines in potentials when it was done that way. Now, obviously, you can't always do it. It depends, especially in cancer surgery, it depends where the cancer is, etc. But in a routine thyroid surgery, I always go to the inferior pole first now. And so that dramatically actually altered how I did surgery. And I'm also very aware now of resting the nerve, particularly if there's been some ventral traction on the lobe. I'm much more aware of the fact that nerve, particularly if it's lifted up a bit, it doesn't like it. It's a little, sometimes very small nerve, and particularly when when the nerve is branched early and there's that tiny little anterior motor branch, that nerve, it does not like being lifted out of its home. And so just, taking the time, even just a minute, letting the thyroid lobe go, maybe doing a little bit of warm irrigation, just letting it sit for a bit, almost invariably will bring those potentials back if they're down. And even if you don't know what the potentials are doing because you're using intermittent, it almost invariably causes a difference between your last stimulation and the stimulation after you've done that in the positive. So I totally agree. I think it does make us more aware of what we're doing and what things we do may be adverse to nerve function. And sometimes it does actually change the way we do things, perhaps for the better.
And you talked at the beginning about superior laryngeal nerve, the external branch of the superior laryngeal nerve, not necessarily monitoring or intermittent monitoring. and as an adjunct. And I think maybe some of the listeners are not aware of that. I find that some of my colleagues, they say, oh, I didn't know you could do that. I wasn't aware of that. What's your take on that? Do you also do that systematically?
I do. And I think that there's a beautiful algorithm actually for that was developed by the International Neural Monitoring Study Group, and it's EBSLN, and I might not be able to remember what all the individual parts stand for, but it's basically, you expose that superior pole and then you develop that Joel space. And then where the thyroid muscle attaches to the thyroid cartilage, almost invariably that little external branch is running very near to that. Now, obviously, it can be slightly displaced in the case of a large goiter, and you need to be very aware of that. But the key to that algorithm is that you stimulate the tissue that you're planning to divide at the superior pole, because this nerve is always damaged at superior pole dissection. And it's kind of, I think about it as the forgotten nerve of thyroid surgery, because the number of patients that I have seen, I work in laryngology as well. And so the number of patients I've seen who have come in with difficulties accessing their head voice, their sort of higher register of voice, after thyroid surgery is dramatic. And, some studies have estimated rates of injury up to 58%. This is a nerve that if you don't look for it, it can really easily be injured, particularly if it's running low on the anterior surface of that superior thyroid lobe. And so you stimulate the tissue that you're planning to divide, and you should get a negative, what we call twitch signal. Now, sometimes you can monitor that signal in the larynx, because there are connections between the external branch and the recurrent nerve, and also the cricothyroid muscle that the external branch supplies does move the larynx, and that can be detected on some of the internal electrodes on the endotracheal tube. But most importantly, we're very lucky with that nerve because it's supplies the one muscle in the larynx that actually sits on the outside of the larynx that we can directly watch with our eyes when we're stimulating for that nerve. And so I don't always visualize the nerve, but I always, if I'm going to divide a little bit of tissue at the superior pole, obviously I look first and see that there's nothing obvious that I can see. Then I probe that tissue, usually at 2 milliamps actually, and sometimes that's too high and you get far field, and then I'll drop it back to 1 milliamp. And then I will probe the tissue medial and superior to that tissue. And if you kind of systematically go sort of from anterior to posterior along that thyroid cartilage, you can find where that nerve is running, and then you can track it down, down to and you can actually see the cricothyroid muscle contracting. And once you've done that and you know that that nerve's up there and the tissue you're going to divide is down here, you can safely divide that bit of tissue, and then you go to the next bit of tissue and the next bit of tissue until you've divided all of that tissue. I actually had a big goiter today where the nerve ran very much on the superior surface, and the nerve can be, it's a small nerve, and even with loops on, you can sometimes not see it clearly. And this was one of those classic cases where if I hadn't been probing for it, I could easily have transected it with the superior pole vessels, even though I was staying right on the thyroid capsule, doing everything right. But this nerve dipped down onto the anterior surface. And so this was just a classic example of why we should probe for that nerve, because the voice implications of a superior laryngeal nerve injury, even though it seems like they should be small given that nerve only supplies one muscle, are pretty catastrophic actually, and people's voices can be really shot. They just have a very monotonal voice. They can't get pitch inflections, they can't express emotions as well. It can be quite catastrophic for people. So yes, that's a form of intermittent monitoring. Continuous monitoring can't monitor that nerve, so that really is why you need to have both forms. I would never just do continuous without having intermittent there, and that's one of the reasons.
Well, that was a really good example, the goiter and the surprise that the nerve is like not really where I expected it to. It's a described anatomic variant. And sometimes, I think maybe it's an argument to use neuromonitoring all the time, because you never know what kind of surprises you're going to have, even with the recurrent nerve, that it might be really adherent to the thyroid capsule or not exactly where you're looking for it. So what you're saying was really an interesting point. I guess this seems like you've got, the endotracheal tube, you've got electrodes, there's a lot of equipment involved. Are there techniques, ways of doing it without equipment or with less equipment in places where you don't have access to these kinds of technologies?
Yeah, no, it's a great question. And the answer is yes. And this has been an area of research by a number of groups, particularly actually in the last 5 years or so. So there's been quite a few publications coming out looking at using needle electrodes or transcutaneous skin electrodes on the thyroid cartilage. So either into the cartilage itself or just sort of sitting in the muscle outside the cartilage or sort of sitting on the skin over the thyroid cartilage at the level of the larynx where the vocal cords would be, and using those electrodes to basically, instead of the endotracheal tube based electrodes, to guide dissection and do nerve monitoring. And those transcartilage electrodes, those electrodes actually they have higher EMG potentials often than the tube-based electrodes. So it is very effective. The negative, of course, is that you've added an extra moving part. So these needle electrodes, of course, can become displaced. In theory, they could cause a hematoma or something for the patient, if they were put in too far and penetrated the airway. But it's a very low-cost alternative to using endotracheal tubes. So saying you still need a monitor to pick up the EMG signals. So it doesn't completely alleviate that requirement, but it does alleviate the requirement of having a separate endotracheal tube for every patient. You can just have a pair of electrodes, which is fairly cheap. And I mean, the other way of doing nerve monitoring without a monitor, just using a probe to stimulate the nerve, would be just to palpate the posterior cricolaryngeal muscle, which sits basically behind at the back of the thyroid, and and that posterior cricoarytenoid muscle at the back of the thyroid, you actually can feel if you sneak your finger around behind the larynx. And so that muscle is the only abductor muscle, meaning the muscle that opens the vocal folds, that we have. And so if that muscle is working, it's reasonable to assume that the adductor muscles, for which there is probably more robust nerve supply almost, are probably working as well. And, in essence, that abductor muscle is probably the more important one, I guess, in terms of breathing. So it's a really good surrogate marker. So it's just sometimes can be a bit awkward to get your finger around the back of the larynx, particularly if there's a big goiter in the way. So that can be a useful approach at the end of a surgery when you are trying to work out, should I go to the other side or is the nerve working? And I must say, the times when I have lost signal in a surgery, I usually will do that to check. And sometimes you'll find that the muscle contracts fine and actually it's a false loss of signal. Something's gone on with the monitoring circuit, and similarly, if you lose signal during a case and you really don't think anything's happened, and it's always a good way of checking whether whether the information you're getting from the nerve monitor is actually true, because of course it's just a tool and sometimes the information it's feeding you is not correct. And so that's a really simple way, and a simple way in areas where monitoring per se is not available. It's a way of ensuring surgery can be done safely, particularly with regards to staging surgery in the case of an ipsilateral loss of signal.
Yeah, that's a really great thing to keep in mind. And again, that some colleagues who don't have experience don't, think about putting the finger behind just to make sure that things are working when the actual machine is not giving us the information that we want. I'm going to go to another question. I mean, so I imagine we've got a lot of surgeons listening in, but maybe if they're non-surgeons listening, what should we as surgeons try to tell or have our non-surgeon colleagues be aware of with neuromonitoring? What should they know so that they understand where we're coming from and how important it is?
So I think, as we sort of discussed briefly previously, we all want what's best for our patients. And I think that this is has become in many countries pretty much standard of care for definitely for revision surgeries and cancer surgeries, and it's surgeries where patients have had prior neck surgery, where dissection may be more difficult. But, in my mind, this is something that is not hard to do. It's not hard to learn how to do as long as you're willing to learn and willing to listen to what the data is telling you. And therefore, if you've got the ability to do it, and if your hospital or practice has a nerve monitoring machine, it seems like that should be the standard of care for all thyroid surgeries if you can do it. Now, we were speaking about regions of the world where that's not possible, and obviously there are situations like that where surrogate forms of monitoring may need to be used, or where monitoring can't be used at all. But definitely in the United States, in most westernized countries, neuromonitoring is possible and it is useful. And not only does it optimize patient outcomes, it also, I think, when you counsel patients preoperatively, it also makes patients feel more confident about you as their surgeon. It also helps them, draw attention to one of the main complications of thyroid surgery, and the fact that, we're doing everything we can to try and prevent that. It's just reassuring to patients to know that one of the major potential complications of thyroid surgery, there are ways of trying to ensure that doesn't happen, other than just trusting your surgeon. We're actually using techniques to show patients that we're doing everything we can. And so I think from a non-surgeon point of view, obviously the nuances of the different techniques, etc., maybe isn't as necessary. But in my mind, nerve monitoring is necessary and should be, when possible, incorporated into the surgical strategy for thyroid tumors, benign thyroid nodules, really for any time when you are operating in that tracheoesophageal groove and have those laryngeal nerves on exposure. And I think it's important because the risk of injuring one of those nerves can be pretty catastrophic for the patient. Voice, we don't really realize how important it is until we don't have it. And particularly people in a professional voice capacity, but also anyone who uses their voice a lot, but can be really, really handicapped by not being able to project their voice, not being able to raise the pitch of their voice. And it can lead to unanticipated time off work. It can lead to significant disability, depression. And I think if we have a way of preventing it, then we should do it.
That's excellent. I think sometimes in my practice, the non-surgeons don't understand like why I had to stop, why I did stage surgery, and I, have to do that. So I think more and more they're getting used to it. And if we talk about, well, we have this way of predicting that we're going to have at least this side is going to be paralyzed probably, and avoid tracheostomies and then avoid catastrophic situations.
I think right, and I think going back to the counselling too. Then, and I do counsel patients who are having total thyroidectomies about the possibility of stage surgery, and I tell them that would be based on my assessment of the nerve function at the time, and being able to tell them that they're not going to end up with a tracheostomy, or at least the risk is negligible, because I will not go ahead and do the other side if the first side nerve is not working. I mean, that gives people a lot of confidence, because that is a real fear of people, that they won't be able to breathe after thyroid surgery. And so I totally agree. I think, being able to explain to your endocrinology colleagues, or other surgical colleagues, why you didn't necessarily do the surgery that was anticipated on the basis of objective data, I think that's really valuable, and no one can really argue with that.
Yeah, absolutely. Well, so this has just been a treasure trove of tips and information. And with your experience in the field, I just want to know if you had words of wisdom for our listeners today.
I guess the words of wisdom are, if you don't use nerve monitoring and are a surgeon, it's a really important area to learn how to do. It's not hard to learn how to do, and it potentially can make your surgery a lot safer, make a patient's outcomes much better. And becoming familiar with basic electrophysiology and what the data is telling you and being able to act on that can enhance your ability as a surgeon and also change the way that you do surgery to a safer technique and definitely change the order in which you do things, as it did for me. I think there are lots of developments in the neuromonitoring realm. I think continuous monitoring is extremely useful, and watch this space. There are other techniques being developed for that, which will, be introduced in upcoming years. And so I think continuous monitoring will become easier for the average surgeon to do as these advances occur. And it may well be that eventually continuous monitoring is something that everyone can do and that really can optimize outcomes, as intermittent monitoring, I think, is doing at the moment. Thank you again so much for asking me to do this. It's a real honor.
And that brings us to the end of this episode of Voices of Wisdom. I'm Dr. Dana Hartle, and it's been a pleasure to host today's conversation on intraoperative neuromonitoring in thyroid surgery, why it matters, how it's used, and what every clinician should know. A heartfelt thank you to Dr. Catherine Sinclair for joining us from Australia and sharing such practical insights from the types of neuromonitoring to global access challenges and her team's latest innovations. Thank you, Catherine, for helping us navigate this important topic with clarity and expertise. If you have any questions or suggestions for future podcasts, please email us at voicesofwisdompodcast@gmail.com. We have an exciting second season ahead of us, so please stay tuned for future episodes. And if you liked our podcast, please subscribe to our webinars, which air live every Friday morning at 8 a.m. Eastern Time, US. TIRO Multidisciplinary Seminars is a series for thyroid clinicians and researchers that covers breakthroughs in thyroid cancer research and treatment in the form of topical journal clubs, state-of-the-art lectures, multidisciplinary tumor boards, and lively panel discussions. Just visit tyro.expert/subscribe or click on the link in the description. Thank you for tuning in to this episode of TIRO's Voices of Wisdom podcast. We'll see you next time. Until then, take care and keep making a difference.